what if the key to preventing a really devastating intimate disease and actually reversing the permanent damage it causes, what if that key was hiding in the DNA of salmon?
I mean, it sounds like science fiction, right?
It really does. But welcome to the deep dive. Today, we are investigating a super fascinating frontier in women's intimate health. And we're asking one core question on your behalf. Can polynucleotides, which is this cutting-edge regenerative therapy, can they actually treat vulvar lichen sclerosus?
Yeah, and to answer that, we're synthesizing a massive stack of recent medical literature for you.
Oh yeah, it's a big stack today.
Huge. We are looking at everything from the latest European clinical guidelines on vulval conditions to brand new 2026 clinical evaluations. Plus, we've got the actual treatment protocols that are being used right now at leading regenerative clinics in the UK, places like Harley Street and My Skin.
Right, so we are really bridging that gap between the bench science and what's happening in the clinical trenches. Yeah. And the reason this specific topic matters to you, whether you are, intimately familiar with this condition or you're just hearing about it for the very first time, is that it represents a total paradigm shift in medicine.
It really is a shift.
Like, we're moving from simply suppressing a painful chronic disease to exploring how we might actually regenerate damaged human tissue, like at a cellular level.
Yeah, but before we get into the regenerative potential of polynucleotides, or PNs as we'll probably call them.
Yeah, PNs is much easier to say.
Definitely. Before we look at PNs, we really have to establish the intense reality of vulvar lichen sclerosus itself, or VLS, and, the heavy-hitting pharmacology that's currently used to manage it.
Right. Because VLS is not just a mild rash.
No, not at all. Oh. VLS is a chronic inflammatory autoimmune skin condition that affects the vulva. The body's immune system essentially goes rogue.
It just starts attacking itself.
Exactly. It mistakenly attacks the healthy mucosal tissue and skin of the vulvar region.
And the sources, they describe a really relentless cascade of symptoms. Yeah. Patients experience severe itching, just unremitting pain, and profound dyspareunia, which is painful sex.
Yeah, the physical toll is massive.
And beyond that immediate sensory pain, the inflammation is systematically dismantling the local tissue architecture.
Yeah.
Like the skin can become thickened and white, almost leather-like, or it can thin out so drastically that it tears with just the slightest friction.
And in severe cases, it can cause the labia to fuse entirely or even bury the clitoris.
Which is just horrifying.
It is. But crucially, untreated VLS carries a 3 to 5% lifetime risk of developing into squamous cell carcinoma.
Wow, wait, so 3 to 5%. That vulvar cancer risk, I imagine, is the primary reason the medical community approaches this with such urgency.
Oh, absolutely. That cancer risk is exactly why the standard first-line medical treatment, the absolute gold standard according to the European clinical guidelines, is, well, it's not a fancy new regenerative therapy. It's the application of ultra-potent topical corticosteroids, specifically a formulation called clobetasol propionate at 0.05%.
Okay, let's unpack this for a second, because I know listeners hear ultra-potent topical corticosteroid, and they immediately think of skin thinning.
Oh, for sure.
Dermatologists are constantly warning us about the dangers of overusing topical steroids on the face or the body. So slathering a super potent steroid onto already compromised, delicate genital tissue, that sounds incredibly counterintuitive.
It sounds completely backwards.
Right. Isn't that dangerous in the long term?
It's a completely logical fear, and honestly, it's one that drives a ton of patient noncompliance. People just stop using it because they're scared.
Which makes sense.
But understanding the mechanism of clobetasol explains why it is so non-negotiable. At a cellular level, clobetasol binds to glucocorticoid receptors inside those local cells.
Okay.
And this binding action effectively shuts down the production of inflammatory cytokines.
Which are the messengers, right?
Exactly. They're the chemical messengers telling the immune system to attack the tissue.
So it's essentially a localized chemical gag order for those rogue immune cells.
That is a perfect way to visualize it, a gag order. And regarding that fear of skin thinning, we actually see a fascinating biological paradox with VLS.
Oh.
Yeah, so while steroids do thin normal skin by inhibiting collagen synthesis over time, VLS often causes an abnormal fibrotic thickening and scarring of the tissue.
Oh, I see.
So the clobetasol intercepts that abnormal scarring process. When it's used correctly as a maintenance therapy, which is typically applying one fingertip unit a couple of times a week after the initial flare-up is controlled, the long-term clinical cohorts show it is incredibly safe.
Okay, so the data backs it up.
It does. It shows a 96% overall response rate for symptom management.
Wow, 96%.
Yeah. And consistent use of these ultra-potent topical steroids is currently the only treatment clinically proven to prevent VLS from progressing into cancer.
So you simply cannot skip the clobetasol. It puts out the autoimmune fire.
Right. It stops the destruction. But that brings us to the massive limitation of traditional pharmacology.
Which is?
The steroids silence the immune attack, sure, but they leave behind tissue that is profoundly altered.
Like a burned-down house.
Exactly. The vulva remains devoid of elasticity. It's highly fragile, and the patient often still experiences severe dryness and painful sex. The steroids do not regenerate the lost architecture.
Okay, so the fire's out, but the house is still ruined, which perfectly opens the door to regenerative medicine, right?
Yes, the cellular rebuilders.
Right, polynucleotides. The protocols from these clinics, like My Skin and Harley Street, they rely heavily on these PNs, and the literature defines them as bioactive molecules consisting of highly purified DNA fragments.
That's right.
But the wild part is, and we touched on this at the very beginning, these specific fragments are derived from the sperm cells of salmon or trout.
I know, it sounds crazy.
It really does. I mean, why fish sperm? Why not, I don't know, plant DNA or some lab-made synthetic alternative?
Well, it comes down to biological compatibility and purity. Salmon DNA is highly conserved, which means its fundamental structure is incredibly similar to human DNA.
Oh, really? I had no idea.
Yeah, but more importantly, the extraction and purification process removes all the proteins that would typically trigger an allergic or immune response in humans.
That's completely stripped down.
Completely. You're left with a pure biological messenger system that the human body recognizes and responds to without rejecting it as a foreign substance.
That's fascinating. But if traditional dermal fillers, like, say, hyaluronic acid, if they just act as a physical volumizer that sits in the tissue and takes up space, how do these purified fish DNA fragments actually interact with us?
Wow.
Because, I mean, we aren't fish.
Yeah.
So how does the communication happen?
Right. So think of polynucleotides not as physical bricks filling a void, but as a software update.
A software update?
Yeah, injected directly into the compromised tissue. When injected intradermally, these PNs bind to specific receptors on the surface of local fibroblasts.
Fibroblasts being the cells that build things, right?
Exactly. They are the cellular factory workers responsible for generating the structural framework of your skin.
So they produce the collagen and elastin.
Yes. The PNs bind to these receptors and literally rewrite the cellular behavior.
Wow.
They stimulate the fibroblasts to massively increase their metabolic activity. So you get a huge boost in the production of type I and type 3 collagen and fresh elastin.
That's incredible.
And it doesn't stop there. They promote angiogenesis, which is the formation of new microblood vessels. So that drastically improves localized blood flow.
Which is crucial for healing.
Absolutely. And they also have a secondary effect where they bind to free radicals, acting as a potent localized antioxidant to calm any lingering low-grade inflammation.
Okay, so some of the specific clinical formulations mentioned in our sources take this even a step further. There's this triple action formula called Nugen.
Yes, Nugen.
And it seems to be a real preferred tool in these clinics right now.
Yeah.
It combines the polynucleotides with hyaluronic acid and a sugar alcohol called mannitol.
Yeah, the inclusion of mannitol in the Nugen formulation is honestly a brilliant piece of pharmacology.
How so?
Well, the human body naturally produces enzymes called hyaluronidases,
Okay.
and their sole job is to break down hyaluronic acid. This is why traditional HA hydration can sometimes just dissipate really quickly in highly inflamed tissue.
Oh, I see. So the mannitol is acting as a chemical shield.
Exactly. It structurally inhibits those hyaluronidase enzymes. By neutralizing them, the mannitol protects the injected hyaluronic acid, allowing it to provide intense, prolonged hydration to that fragile VLS tissue.
While the polynucleotides are doing the slower work.
Right. The slower, more complex work of cellular reprogramming and collagen synthesis.
That is so smart. But, you know, a listener might wonder, if someone is dealing with VLS-induced dryness or even just postmenopausal atrophy, why wouldn't they just use localized estrogen cream?
This is a very common question.
Like, why opt for injectable fish DNA over a standard hormonal treatment?
Well, localized hormones are highly effective for many women, for sure. But the specific degradations seen in VLS, like the severe depletion of microblood vessels and elastic fibers, it sometimes requires a more direct structural intervention.
Okay.
And more importantly, polynucleotides offer a vital, non-hormonal pathway.
Which is an absolute lifeline for oncology
It's a
patients.
total lifeline.
Because women who have survived breast cancer or any hormone receptor positive cancer, they often have hormone replacement therapy strictly removed from their options.
Exactly. Their estrogen is artificially suppressed to prevent the cancer from coming back, which plunges them into sudden, really severe urogenital atrophy.
And PNs give them a method to physically regenerate that intimate tissue and relieve the pain without introducing any systemic hormonal risks.
Right. But, moving from the biochemical theory to real-world application, we have to look at the clinical evidence. Does this actually work in patients?
Yeah, let's look at the data. I know there's a brand new 2026 preliminary evaluation by Terranoti and colleagues, and they specifically investigate injecting hyaluronic acid and PNs directly into patients with vulvar lichen sclerosus. They track the outcomes using the Female Sexual Function Index to measure the objective changes in the tissue behavior and just overall patient comfort.
Right. And to really understand the profound impact of this targeted therapy, the sources also highlight the Palmieri study on PNHPT.
Which stands for polynucleotides, highly purified technology.
Exactly. This observational cohort followed 47 women who were suffering from severe vulvovaginal atrophy and the resulting sexual disruption.
So what did they do?
They received 5 targeted polynucleotide injections into the labia and vestibular areas over the course of several weeks.
Yeah, and the researchers utilized this validated psychometric tool called the PR scale, right? The personal assessment of intimacy in relationships.
They did. And the physical markers, the vaginal dryness, the painful sex, those dropped significantly as the tissue regenerated.
Which is amazing on its own.
It is, but the psychological data honestly provides the most compelling insight.
Because treating intimate tissue isn't just about restoring dermal thickness. It's about restoring a patient's connection to their own body and to their partner.
Exactly. The pair scale separates day-to-day non-sexual relationship dynamics from specific sexual gratification.
Okay?
And the study revealed that while everyday non-sexual relationship scores stayed pretty stable, 5 out of the 6 specific indicators tracking the woman's personal sexual gratification saw statistically significant improvement.
Wow. 5 out of 6.
Yeah. We are looking at measurable data where women report a restored ability to engage in and actually enjoy intimacy without the barrier of physical pain.
That structural restoration is just remarkable. But I think we need to establish a very clear boundary for the listener here regarding expectations.
Definitely.
Does the injection of polynucleotides, this whole cellular reprogramming thing, does it actually cure the underlying vulvar lichen sclerosus?
It does not.
Okay, that's important to clarify.
It's very important. There is currently no known cure for the autoimmune mechanism that drives DLS. Polynucleotides are a highly advanced symptomatic and structural treatment, but they are not an immunological cure.
So going back to our house fire analogy, if the clobeptidosol steroid is the fire extinguisher putting out the flames, the polynucleotides are the architects rebuilding the charred scaffolding.
Yes. They heal the microtears, they restore the lost elasticity, and they bring profound hydration back to the area.
But if a patient abandons their steroid maintenance therapy,
Then that underlying autoimmune fire will spark right back up, and it will begin destroying the newly generated tissue all over again.
okay, so it's an architectural intervention, not an immune reset.
Exactly.
And understanding that limitation naturally brings us to how PNs compare to the rest of the regenerative toolkit. Because this field is expanding rapidly, and PNs are definitely not the only option out there.
Oh no, the aesthetic and regenerative gynecology space is booming.
Right. Our sources detail a few other major treatments dominating the space. There's PRP, or platelet-rich plasma, which is frequently marketed in clinics as the O-shot.
Yes.
There's autologous fat grafting, or lipofilling, where they transfer fat from another area of the body to the vulva. And then there's this massive surge in energy-based devices, specifically radiofrequency microneedling like the Morpheus 8V, or fractional CO2 lasers.
Right.
So if a patient is staring down this long list of options, why might a clinic steer them toward PNs over, say, a laser treatment?
Well, it requires balancing efficacy with the specific vulnerabilities of VLS tissue. Consider the mechanism of energy-based devices.
Mhm.
CO2 lasers and radiofrequency technologies, they operate on the principle of controlled thermal trauma,
They're essentially burning the tissue on purpose.
basically. They intentionally heat the delicate vaginal and vulvar tissue to roughly 40 to 42 degrees Celsius to trigger a wound healing cascade, which ultimately produces collagen.
But wait, for a patient whose tissue is already hyperinflamed, already compromised, and painfully sensitive because of the VLS, subjecting that area to intense thermal trauma seems incredibly risky.
It does. It could easily aggravate the baseline inflammation.
That makes total sense.
That is the primary concern for many practitioners treating autoimmune conditions with lasers. Then you evaluate PRP. Platelet-rich plasma is an excellent regenerative modality, utilizing the patient's own growth factors.
But there's a catch.
Well, it requires a blood draw, spinning that blood in a centrifuge to separate the plasma, and then re-injecting it.
So it's a whole multi-step biological extraction
Right.
process.
The polynucleotides bypass both the thermal trauma of the lasers and the biological processing of PRP. You're getting the profound cellular signaling and structural regeneration, but from a highly purified, off-the-shelf biologic.
It represents a much more streamlined, purely biochemical intervention.
Exactly. But we also have to address the tension between this rapid clinical innovation and official medical policy.
Right, because they don't always move at the same speed.
Not at all. Private regenerative clinics are successfully deploying these treatments right now, but official European and British medical guidelines maintain a very cautious stance.
As is typical.
Yeah. The 2021 European guidelines explicitly state that the evidence for stem cells, PRP, and similar regenerative therapies is weak when you compare it to the decades of robust data supporting topical steroids.
So the guidelines are basically waiting on the massive, multi-year, randomized controlled trials to validate what the private practitioners are already seeing in their patients.
Exactly. The burden of proof to change a national medical guideline is rightfully enormous.
And those rigorous trials are currently underway, right?
Yeah, they are.
Our sources highlight a major 3-arm clinical trial running at Jagiellonian University, scheduled to conclude in late 2026.
Yes. Researchers are taking 45 women with confirmed VLS and dividing them into 3 distinct treatment protocols. One group gets the gold standard clobetasol, the second group receives a calcineurin inhibitor, and the third group receives regenerative PRP injections.
What makes a trial like that so definitive? Like, how do they measure success beyond a patient just saying, oh, I feel better?
They are performing physical tissue biopsies at the 6-month mark.
Oh, wow.
Yeah. They're looking at the tissue under a microscope to definitively track cellular changes, measuring the reduction in inflammatory markers against the physical generation of new collagen and elastin fibers.
So it's very objective.
Highly objective. This is the heavy scientific lifting required to integrate regenerative medicine into standard, insured gynecological care.
Okay, so synthesizing all of this data. For the listener navigating a vulvar lichen sclerosus diagnosis today, the landscape can feel really fragmented.
It really can.
On one side, you have the official guidelines mandating steroids. On the other, you have cutting-edge clinics offering cellular reprogramming with fish DNA. What is the most effective roadmap for a patient right now?
Well, the evolution of modern care for complex conditions is inherently multidisciplinary. The data suggests the most advanced protocol available today is a synchronized dual approach.
Meaning you do both.
Exactly. A patient must utilize the gold standard ultrapotent steroids to suppress the rogue immune response, halt the disease's progression, and neutralize the risk of cancer.
The cancer prevention is non-negotiable. The fire must be put out.
Once the active disease is stabilized and the tissue is quiet, the patient no longer has to accept permanent atrophy and painful intimacy as a lifelong sentence.
Right.
They can integrate targeted regenerative therapies, like polynucleotides, to physically rewrite the behavior of their fibroblasts, regenerate the lost collagen scaffolding, and restore the tissue's resilience. The steroids protect the patient's life. The polynucleotides restore their quality of life.
I love that phrasing. We have covered incredible ground today. We explored the destructive cellular mechanisms of VLS and unpacked the paradox of clobetasol, how a powerful steroid actually prevents abnormal scarring and shields the patient from vulvar cancer.
Yeah.
We then look at the biochemistry of salmon-derived polynucleotides, acting as a biological software update to literally command human tissue to rebuild itself.
It places the patient in an active role of cellular regeneration, rather than just passively managing their structural decline.
Exactly. But before we conclude this deep dive, consider the trajectory of this science. We established that current regenerative therapies repair the damage, while steroids suppress the underlying autoimmune fire. But, as this biochemical technology advances,
Could the future of treating conditions like VLS lie in engineering the target tissue to be so structurally resilient, so deeply hydrated, and so inherently regenerative that the autoimmune mechanism simply cannot gain a foothold to cause damage in the first place?
what if we can program the tissue to just outbuild the disease? Something for you to ponder. Thanks for diving deep with us today.